keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello, my name is Dr. Vaskin Dilsizian. I'm Associate Editor of JACC Imaging. With me in the studio is Dr. James Udelson, who's Chief of Cardiology at Tufts Medical Center. Dr. Udelson, welcome.
Thank you, Vaskin.
We're going to be talking about a paper where you wrote an editorial on. The paper comes from Dr. Nakata's lab from Japan. It's a multi-center prospective study. It's an observational study, over 3,800 patients who have either coronary disease or suspected to have coronary artery disease, underwent myocardial perfusion gated SPECT study, and they were followed over the next 3 years. And the primary purpose of the study was to look for cardiac events and outcomes, including death. And what they noted was over half of the events were actually heart failure. So when they went back and eliminated those with heart failure to begin with, trying to see what are the predictive parameters, clinical or imaging, that would predict new onset of heart failure, they found out that 3 stood up very nicely. One was the sum stress score, moderate to severe defect. Second was the end systolic volume index, and the third, chronic insufficiency. Now, could you place the findings in the proper clinical context of heart failure?
Sure. I think what my colleague Dr. Soman and I found so interesting as he co-wrote the editorial with me was that as you know, most of the prognostic literature using SPECT imaging focuses on predicting death or myocardial infarction. So there really aren't that many papers that look at data sets for prediction of incident heart failure or new-onset heart failure. And when you think about the ACCHA guidelines on heart failure over the last few years, the emphasis has shifted somewhat to a staging system which is more preventative in concept, that there are stage A patients who have some risk factors for heart failure, stage B patients who have something amiss with their left ventricle but have not developed symptoms yet, and then symptomatic stage C and end stage D, with the idea that if you can step in at stage A or particularly B to prevent the onset of symptoms, that is an important public health imperative. So what was intriguing about this data set was, number one, the endpoint, incident heart failure, and the suggestion that perhaps you could use the information from the gated SPECT imaging combined with renal function to perhaps, and this remains speculative, picking out a group of people at high risk for developing heart failure and stepping in with a preventative therapy.
Now, the importance of this, I would think that even though we have great medical therapy for heart failure, the morbidity mortality remains very high. So there is tendency for prevention, and this paper at least is one step towards that.
That's right.
And doing some type of non-invasive imaging along with clinical parameters to prevent progression of heart failure before medical therapy is effective.
That's right. And in otherwise very stable people who don't have a suspicion of heart failure, they're being referred for suspected CAD. And so, the keys here are the comprehensive nature of the gated SPECT exam, not only looking at just perfusion, but the end systolic volume. So that was a key discriminator here. And another really novel point about this paper was the incorporation of renal function. So you don't know, most of the imaging papers, as you know, are imaging predicts prognosis on top of some clinical data. But here, weaving in the renal function information is very consistent with the heart failure literature, that as renal function declines, your risk of worsening heart failure is worse as well. So this was a very important aspect of the paper.
So even though therapeutics was not part of the study, could you project forward? How would you use this data in treating patients differently than you would?
Right. This was just really an observational data set, but you can imagine a scenario if you had a report on a patient with a slightly enlarged end systolic volume, some stress score, in other words, extent of scar or ischemia that you might not otherwise have suspected, and mild renal dysfunction, putting that patient really into one of these fairly high risk categories for incident heart failure. You could imagine as a clinician considering the possibility of ACE inhibitors where you might not otherwise have done that.
And you wouldn't worry about renal insufficiency in these patients?
You would a little bit, but there's somewhat of a paradoxical literature that, most of the randomized trials exclude people with moderate to severe renal dysfunction. But there are observational data suggesting that ACE inhibitors may actually be even more important. But you do have to use them very carefully, of course. And so it depends on the degree of renal dysfunction. But of course, in diabetics with subclinical renal disease, we use ACE inhibitors to prevent progression of renal dysfunction. So the intriguing aspect of this paper was the multiple pieces of physiologic information that tie together to sort of predict the risk of a very important onset of symptoms of heart failure.
And in final point, if we could put it together, as you know, the most challenging part of heart failure diagnosis is whether it's ischemic or non-ischemic cardiomyopathy. Discussion about non-invasive approach first versus coronary angiography, but that's for detection of disease. Realizing the high negative predictive value of myocardial perfusion studies would now prognosis or prediction of subsequent heart failure, should that be also part of the schema, if you will, of managing patients?
Yes.
Or, I know it's too early, but...
Well, I mean, it does come wrapped up really in one test. I mean, if perfusion is normal, but volumes are slightly large, well, that patient probably has some risk of incident heart failure, but it's unlikely to be, on the basis of coronary, it's unlikely to be ischemic cardiomyopathy. So, and there is some management implications there. So the diagnostic information or etiology of heart failure down the line, and then the prognostic information together form a rather complete picture.
Thank you very much, Dr. Udelson. This was an exciting paper. However, it still is preliminary and observational. We look forward to a larger prospective trials to clarify this further in a very important patient subset of heart failure. Thank you very much.